Okay, so this is the second part of cardiology questions for USMLE Step-1 that we're going to do. Let's start with this question. A 40-year-old woman comes to the physician because of 6-month history of exertional dyspnea, non-productive cough, dysphagia, and burning chest pain. Her chest pain is aggravated by lying down, especially after a heavy meal. She also reports that her fingers turn pale and becomes painful on cold exposure. Her pulse is 80 per minute, respirations are 18 per minute, temperature is 37.6, and blood pressure is 155 over 95 millimeters of mercury. Physical examination shows tight, smooth, shiny, thick skin without wrinkles. Which of the following sets of cardiovascular changes in this patient are most likely to be seen? Okay, well, it looks like we have a question that shows you multiple symptoms from multiple systems, so it's multi-system disease. And then at the end, all they want to know is what are the effect in the cardiovascular system. Okay. Well, just by reading these questions, I'm getting the sense this is scleroderma. Okay, so let's first diagnose the condition, because once we diagnose the condition, then we know what's the cause of that disease, and then that can guide us what do we expect in terms of cardiovascular changes. If it is scleroderma, for now, let's say it is scleroderma. I know it is. So scleroderma. Now, to know what is scleroderma, it is really important for us to know. Okay, so number one, scleroderma is autoimmune disease, okay, in which fibroblasts are superactivated. So by usually by CD8 or antibodies, these fibroblasts are superactivated. It's autoimmune fibroblast activation, and I will just put a plus sign, which means activation. Therefore, if you superactivate fibroblast, what do? They produce fibers, and that will lead to, especially like collagen, and that will lead to fibrosis. Okay, so the end result is fibrosis, where multiple organs. The most important, the most common organ that is affected by this fibrosis is skin. Okay, skin. So what do we expect in skin? Skin becomes thick. What is fibrosis? It becomes thick, shiny, dry, itchy, almost like leathery, almost like a leather skin. You know, if you take a leather, that's how it would be. I don't know if that's how I spell leather, but you guys can help me as well. Okay, so the skin is like a leather, so I'll say leathery skin. Look for that, shiny, greasy. I can even put here greasy to some extent. It is dry, greasy kind of thing, like dry leather. Okay, so look for that. This is one of the most common symptoms, and they will always give you that to make, if they want you to know that this is scleroderma, then they will always give you that. The reason they'll give you that is because they want you to know it's scleroderma. Why? Because the question is not about diagnosis. The question is a two-step question. They want you to know what are the effects of scleroderma on heart. Okay. Next thing that's really commonly involved is the esophagus. And guess what happens in esophagus? Esophagus dysmotility increases. Remember, the smooth muscle of esophagus, if it goes under fibrosis, it becomes stiff. If it becomes stiff, peristalsis is affected. So it leads to dysphagia. So swallowing becomes difficult. Okay. In addition to that, LES is affected, so it can lead to acid reflux or GERD. Okay. So that would be esophagus. And the next thing that's very commonly affected is lungs. And in lungs, it leads to, imagine, okay, so this is almost the same as in pneumoconiosis, silicosis, asbestosis, hemochromatosis, all those conditions, or amyloidosis, where you have deposit of foreign particles in the lungs. Okay, so this leads to restrictive lung diseases. Restrictive lung disease. Okay, in restrictive lung disease, remember all values are decreased except the ratio is increased. So now the symptoms of restrictive lung disease would be dyspnea, shortness of breath with exertion. So I would say exertional, exertional dyspnea or shortness of breath with exertion activity. And there will be dry cough. You put dry, I'm just going to put cough, dry cough. Fine crackles are really important. Fine crackles. Okay. And so that would be the lung thing. But remember that also restrictive lung disease can lead to cor pulmonale. Cor pulmonale. And that would be the right heart failure, right? So in addition to that, so look for those things. Uh, next thing that is, now let's put heart. Heart is also involved. So in heart, if you have fibrosis of heart ventricle and so forth, that will lead to restrictive cardiomyopathy. Just like restrictive lung disease, this leads to restrictive cardiomyopathy. And you should know these diseases, like this is the thing. This is a systemic disease. So it's a great question because it's testing so many concepts. Cardiomyopathy, restrictive cardiomyopathy. In restrictive cardiomyopathy, what's the issue? The issue is filling is the problem. Okay, filling. It's ventricular filling that is affected. So filling failure. Okay, filling failure. So the ventricle doesn't fill properly, and then there's compliance, right? The heart doesn't expand. So so the most important chamber in the heart is the left ventricle. So the left ventricle doesn't expand completely. It's stiff. Okay, so stiff heart. I'll put stiff heart. You can focus on the ventricle. Filling failure, stiff heart, and the heart is restricted. It is stiff. It doesn't fill completely. So it's a diastolic heart failure essentially. Okay. All right. Also, it affects blood vessels. So when the vessels become stiff, what does it lead to? Hypertension. I'll just put hypertension. Okay, so that's one huge complication. And of course, these vessels become super sensitive to, if the layers become stiff, then they don't go under like vasodilation so easily. They become constricted, so and become super sensitive. So this can lead to Raynaud's phenomena. Raynaud's. Remember, Raynaud's phenomena is your blood vessels will constrict upon cold exposure, and that can lead to what? That can lead to cyanosis of your fingertip. The fingertips can turn blue. Okay, so that's one more thing. And then the next thing is, of course, these things can accumulate in joints. Deposition of abnormal collagen leads to fibrosis of joints, and that can lead to arthritis and arthralgia. Okay, arthritis or arthralgia. Joint pain, and eventually can lead to joint inflammation, but initially pain, then eventually. Okay, good. So this is the diagnosis of scleroderma. Okay, now let's see what are these symptoms present in our clinical scenario. Do we have these? So before we go there, let me just give you some more information. All autoimmune diseases, remember this, please remember this. Autoimmune, I already wrote it up there, but all autoimmune diseases are more common in female. All of them. Okay, so this is most, and usually female in their 30s, that's when it's like the peak. So that's one. And all autoimmune diseases are, and especially more autoimmune disease tends to be more common in African American or Black. African American, I'll just put AA. Okay, if you were to diagnose autoimmune diseases, what are you looking for? Well, you'd be looking for antibodies. You'd be looking for something like this. So anti-nuclear antibody, which is abbreviated as ANA. Look for that. So the antibody involved in scleroderma are what? Anti-nuclear antibody, which is common in other autoimmune diseases as well. This is sensitive. So ANA is very sensitive. Okay, it's not specific. So remember the stats questions, biostatistics questions, sensitivity, specificity. So ANA is more sensitive. Okay, and then but anti-topoisomerase, which is an enzyme responsible for DNA replication, right? Topoisomerase is more specific, okay, and that is for scleroderma, systemic scleroderma. But also you should be looking for anti-centromere antibodies. Centromere is the middle of, or a point where two chromatids are held as a single chromosome, or two center chromosomes. Okay, centromere is positive, so these. But anticentromere is more for CREST syndrome. Okay, so just look for those. Limited scleroderma is centromere, and general systemic scleroderma is topoisomerase. So I'll be looking for these. So um, just since we're talking about, I'll just mention one more thing. Corticosteroids are a very common therapy, the drug of choice in most cases for all autoimmune diseases. Okay, so this gives you a good scenario. Now we go back to our question to see what are some clues in this that tells us this is scleroderma. So we see a 40-year-old female, 40-year-old woman. We said that this is common to all autoimmune disease. So this tells us that this is autoimmune disease. Now we're suspicious. Okay, comes to the physician because of 6 months history of exertional dyspnea. There you go. Exertional dyspnea. Look in lungs. We have a restrictive lung disease. We said dyspnea. That is with activity. So the person who has restrictive lung disease with exercise, activity, jogging, walking upstairs, downstairs, walking miles, will have dyspnea, shortness of breath, and they will have dry cough. In this question, let's see if this cough, non-productive cough, is the same thing as dry cough. So yeah, they will have dry cough. Dysphagia in this question is there, and that will be more esophagus. Remember, so esophageal dysmotility, stiffness of the esophagus, leads to decreased peristalsis, so that will be dysphagia. Burning chest pain is a complication of LES. Again, that's also there. So far we have, they're talking about lungs, about the GI system. Okay. Her chest pain is aggravated by lying down. Remember, when chest pain is positional, it's not MI, it's not angina. Okay. It could be pneumonia, it could be lung, it could be GERD. Okay. Aggravated by lying down, especially after heavy meals. As soon as you mention heavy meals, we know this is GERD. Okay. Because acid production, so when you eat a lot of food, you need more acids to digest that food, and there'll be more churning of your stomach, right? And that means the risk of reflux into the esophagus is much, much more likely, especially if the LES is patent, it doesn't close completely, or incompetent. Okay. She also reports that her fingers turn pale and become painful on cold exposure, which is the Raynaud's phenomena. So we have Raynaud's phenomena in the vascular component. There you go. Her pulse is 80, respiration is 18, and temperature is normal. Blood pressure is high, 155/95. So there you go, we see hypertension. Physical examination shows tight, smooth, shiny, thick skin without wrinkles, and that is the skin component. So here you go. They talk about everything except the heart. Okay. Which of the following sets of cardiovascular changes in these patients are most likely? But they want to know about the heart. I get it. Okay. Since now we know how to diagnose scleroderma, number one, it is fibrosis. It's systemic fibrosis. Multiple organs are fibrosed in this disease. And then you should know it's common in female. Make sure you know the antibodies involved. If it's autoimmune, you should know. If it's established autoimmune, then you should know what are the antibodies or CD8 cells that cause this damage or inflammation. Okay. All right. So now let's go to these options. I will change my color to, let's change it to yellow. Yellow. Okay. So first we want to left ventricular diastolic compliance. Okay, what does that even mean? So you understand what left ventricle means, right? Compliance simply means stretchability. It's asking you, does the left ventricle stretch more or less or normal in scleroderma? We already discussed that Scleroderma cause restrictive heart diseases, right? Restrictive heart diseases, restrictive cardiomyopathy. Therefore, the left ventricle becomes stiff, and it fails to accommodate more blood. So it doesn't stretch. Its stretchability is decreased. Therefore, its compliance is decreased. Okay, so left ventricular diastolic compliance should be decreased. Okay, so if it is decreased, then it means it's one of these. The bottom four are all decreased, right? So the upper part is no. So no, because we expect the left ventricular compliance to be decreased, not increased. Increased compliance means the ventricle is more stretchable. It accommodates more fluid, more blood. Okay, so diastolic compliance is decreased. So it'd be either EF or GH, one of those. Let's go back to, so that's one thing. The next thing is, let me use green because I don't want to keep changing color. Mean pulmonary arterial pressure. Okay, so in lungs, if the lungs go under fibrosis, right? If the lung goes under fibrosis, that means they become stiff, rigid, they become restricted, so blood vessel will not be able to expand. So the blood vessel become constricted. Plus, it also is vascular fibrosis. So it's stiffness of blood vessels in the lungs. And that lead to pulmonary fibrosis. Pulmonary fibrosis eventually causes increased arterial pressure. Increase pulmonary artery pressure. Increase pulmonary artery pressure. Okay. If that is the case, this eventually leads to increased pulmonary hypertension and eventually leads to right atrial hypertrophy and failure, which is called cor pulmonale. So we're looking for mean pulmonary arterial pressure to be increased. So since the bottom four were correct answers, this is increased and this is increased, but the rest of them are decreased. So this is not the answer, this is not the answer, and we already said these are not the answers. So we're left with either E or F, but that answer will depend on what we get from coronary vascular resistance. It's the same thing. Blood vessel everywhere should be constricted, stiff, and resistance should be increased. And we would expect coronary vascular resistance to be increased. And out of the choices that are left is E. So E is our correct answer, and E is the choice. Okay? So there you go. Let me highlight it for E. Hopefully this answers your question. Let's go to the next question. So next question is talking about a 24-year-old woman comes to the physician for examination prior to employment. Physical examination shows no abnormalities. An EKG shows a sinus rhythm of 70 per minute, which is normal. PR interval of 150 milliseconds, which is normal, and QRS complex of 84 milliseconds, which is normal. There are no ectopic beats. Which of the following best represents the longest conduction time in this patient? Okay, they're just giving all scenario of the normal heart, but they want to know which segment gives you the longest conduction. So that means they want to know the velocity within the cardiac electric system. Okay, now to do that, let's do this. If I were to draw a heart, I like to be perfectionist, I don't know why, but when I make a mistake, it takes me longer to fix it. There you go. So this is the heart. Left atrium, right atrium, left ventricle, right ventricle. Okay, let's use red, or let's use green. Yeah, let me use green. Okay, so green. Here we have the SA node. Maybe I can use my other pen. Which one was it? Is it this? I think it's this. Yeah. No. Let me go back and do this. When I do this, so I want to make it less thicker. Oh, there you go. Just to give me some. Okay. So here you go. This is the SA node. From SA node, there will be. Okay, so that's SA node, and then this is the AV node. You can say the AV node is actually like right here. Okay. So now the SA nodes, there'll be fibers coming from the SA node to AV node. So that's one. And then there is a tract or bundle going from SA node to the left atrium. Okay, left atrium. And then we should have bundle of his. Bundle of his then can split into the right and left bundle branch blocks, right? I think this is not good. Let me use red. Sorry, I should use red. So red. Okay, you know what? I'm gonna use red because so that we can see. So let's say SA node. That was more visible to everyone. And then AV node. Internodal tracts 1, 2, 3, anterior, posterior, and middle, something like that. And then you have bundle of his going through here, and bundle of his will split into the right bundle branch and then the left bundle branch. Okay, and then interatrial tract or bundle, whatever you want to call them. So let's label them. Let me change my pen. So here, this is the SA node, AV node. Okay, and right here, this is the internodal tract, or bundle. You can call it bundle or tract, whichever one you prefer. Okay, so in our choices, SA node is A, so I'm going to do this is A, and internodal tract is B. Let's label this B. So for now, I'm just going to label those. Bundle of Bachman is C, which is this one. So that's C. Okay. So C. And then we have AV node. AV node is D. This is the AV node or D right here. And then what do we have? Bundle of his. Bundle of his is E. So that's E. And then left bundle branch is, what is left bundle branch? F. Okay, that's F. And the right bundle branch is G. And the Purkinje fibers. So Purkinje fibers will be coming from here, like the smaller ones from each bundle branch. So Purkinje fibers, and that's H, right? Okay, so there you go. Now we have labeled our heart. This is the normal conduction pathway of electric impulses that starts in the SA node, and then you go to the AV node. From AV node, it will go to bundle of his. From bundle of his, it'll go to the right and left bundle, and eventually to Purkinje fibers. Okay. All right, internodal are responsible for contraction of the atria in Bachman's bundle, as well for the left atria in bundle of his, and eventually right and left bundle of Purkinje fiber for the ventricular contraction. Okay, now the question they're asking, which one has the longest conduction time in this patient? Okay, the general rule is this, and I'm going to give it to this general rule. Atria, so let's start with atria. Conduction velocity in atria is about 1 meter per second. 1 meter per second. In ventricle is the same. In ventricle is also 1 meter per second. 1 meter per second. Okay, and what's next from this? Let's say AV node, right? AV node. AV node, it is 0.02 meter per second. And the next one we'll do Purkinje fiber, which is okay. And the next one is Purkinje fibers, right? Purkinje. How do I spell Purkinje? Purkinje, it's right here anyways. Okay, Purkinje. It's choice H. Purkinje fibers, the speed is maximum speed is about 4 meter per second, which is very high. Okay. All right. So they're asking which one takes the longest conduction time, which means which one is the slowest. The choices that I gave you right now, the one I wrote, the slowest is the AV node. AV node. This, if you memorize this, look, no one's going to ever ask you about each bundle, each part. General rule is as long as you know the AV node is the slowest and Purkinje is the fastest, that's good enough. So for me, this is a strict memorization, so choice D is the best option. Okay. So SA node, it's very slow. It doesn't even have, because it generates the electric potential. So internodal tract and Bachman's tract is the same. It's 1 millimeter. Let me go write it down for you guys so that we can see. So the slowest SA node is not, there's no conduction because it's generator. The SA node is the pacemaker. So it's a generator of the electric impulse. Electric impulse then travels in the internodal at a speed of 1 meter per second. In the Bachman's, 1 meter per second. Okay. In the AV node, it travels about 0.02. It's actually 0.01 to 0.05. I chose 2 because it's in the middle. Okay. Meter per second. The reason for that is the reason electric impulses in the AV node are so slow. So when the impulse from the atria comes to the AV node causes this impulses to delay. It puts a stop to it. It delays it. Why? So it gives time for the ventricles to fill up with blood and the atria to contract first and then the ventricle to contract. Because if the atria and the ventricle contract at the same time, blood is going nowhere. So the whole idea is for diastole to finish and then systole to occur. Okay. So I should say ventricular diastole occurs first and then ventricular systole. Okay. In bundle of his, it is 1, and left bundle and the right bundle, it's 1, 1. And Purkinje fiber, it is 4 meter per second, the fastest one. Okay, so that's all they were asking. This is a simple physiology answer. So they just want to know where is the high speed or where is the conduction the slowest. The fastest is the Purkinje fiber, the slowest in the AV node. Okay, so hopefully this answers the question. And then let's go to next question. Okay, so this question is talking about an 80-year-old man with a 20-year history of poorly controlled hypertension. Comes to the physician's office because of 6-week history of progressive shortness of breath with exertion. He has had difficulty jogging 1 city block. His home medication include amlodipine and lisinopril for hypertension and naproxen for osteoarthritis. His temperature is 37, pulse is 72, respirations are 18, and blood pressure is 170/96. Pulse oximetry and room air shows an oxygen saturation is 95%. Physical examination reveals S4 bilateral crackles at the lung bases and are heard. That should say bilateral crackles at the lung bases and 12 centimeter jugular venous distension above the sternal angle. Echocardiogram shows a normal ejection fraction. Which of the following best explains this patient's symptoms? Okay, now me reading through this entire questions, I'm getting the impression of CHF due to hypertension. Okay, so let's do that. Let's say this person's having congestive heart failure. How do we know that? So when you think of congestive heart failure, we will always now there's the difficulty. I think I should spend time on this question because I should say this: 95% of the time congestive heart failure is left heart failure. Only a minority of the time it is right heart failure. So let's differentiate between the two, because I was going to give you symptoms of left heart failure only, which is the most common. So let's say right heart failure and left heart failure. Okay, and that's important because as I said, let's just say left heart failure is almost 96% of the time, very common. and the number one cause of right heart failure is left heart failure. So you will rarely see right heart failure without right heart failure without left heart failure. So most of the heart failure is what? Left heart failure, 96% of the time. But if there is a right heart failure, then the number one cause of right heart failure is left heart failure. So that kind of tells you that whenever you see right heart failure, you should expect left heart failure as well. Okay, unless it's selectively due to COPD, which leads to cor pulmonale or right valvular diseases or stenosis. Okay, all right. So in left heart failure, if the heart is unable to pump, okay, if the heart is unable to pump or fill up completely in the case of left heart failure, so blood will start pooling in the pulmonary vessels. So this leads to pulmonary edema. This is the hallmark of left heart failure. So always look for pulmonary edema. In the right heart failure, you will be looking for ankle edema. Ankle edema. Again, remember, if you only have pulmonary edema, then you'll be thinking of left heart failure only. But if you have right heart failure as well, signs of not just ankle edema, other signs, then you'll be thinking of right heart failure as well. Okay, so if there is a pulmonary edema, the signs of pulmonary edemas are what? It is cough, okay, cough, especially positional cough, such as orthopnea. So you can have shortness of breath and cough when you lay down, and there will be crackles, okay, because there's fluid in the lungs. So these are the signs of that. Ankle edema, or oh my God, you know what? I should say peripheral edema, I'm sorry. So pulmonary edema in this case and peripheral edema. Pulmonary edema is central edema, peripheral edema. Now peripheral edema, what are the signs of peripheral edema? It is ankle edema of the ankle, right? So you can ask the patient to lift their socks if they're wearing socks, and you check it out. So ankle edema, you can look for hepatosplenomegaly or liver and spleen congestion. I'll just put hepatosplenomegaly, but they can be enlarged for other reasons too. But in this case, there'll be congestion. They'll be full of fluid. So hepatospleno congestion of the liver and the spleen. Okay, and you can also look for something else, and that is hepatojugular reflux. Okay, and of course you will be looking for JVD, which is jugular venous distension. Okay, jugular venous distension. So look for these signs. That'll be is typical of these things. Plus, you can have pulmonary edema if there is increased pulmonary pressure, pulmonary vascular pressure, right? And you can measure that by something known as pulmonary capillary wedge pressure, which should be increased in the left heart failure. But pulmonary capillary wedge pressure will be decreased in the right, or normal at least. If not decreased, let's just put decreased or normal in the right heart failure. So these are something to differentiate. You can usually use the heart sound. S4 is typically associated with right heart failure, and S3 is typically associated with left heart failure. Okay, but it's not so synonymous, but you can look for those things. Another thing that you can look for is ANP, atrial natriuretic peptide, is increased in right heart failure, and BNP is increased in left heart failure. You can also look for displaced PMI and so forth, but this is enough. So now, so signs of heart failure, you should know. These are signs of heart failure. Okay. Let's see if we have these signs. Okay. I think I remember in this case the issue was hypertension, right? Yeah, the issue was hypertension. So let's do this. The main thing in this person was there was hypertension. Remember, if there's hypertension, that means the aortic valve is hard to open. If there's a lot of blood, a lot of pressure in aorta, That is hypertension. Hypertension means increased pressure in vessels, especially in arteries. Increased pressure in arteries. Okay, hypertension means increased fluid pressure in arteries, not in veins. So the most important vessel in that case is aorta. So if aorta has a lot of blood in it, a lot of fluid, it's going to push on the aortic valve and keep it shut. It's difficult to open. So which means you need a higher pressure to open it. Normally we know that the blood pressure is 120 over 80. 120 is the systolic pressure, which is ventricular contraction causes that. Diastolic pressure is 80. So if there's 80 diastolic pressure, that means you at least need the left ventricular pressure to be 81 to open the aortic valve. But in this case, let's talk about this person. In this person, what is his blood pressure? Where is it? Where is it? Right here. Look at the diastolic pressure. Diastolic pressure is 96 millimeters of mercury. So diastolic pressure is the pressure when the heart is not contracting. That's not during systole, right? That's when the heart is relaxing, the left ventricle is relaxing. Systolic pressure is when the left ventricle contracts and squeezes and pushes blood through aortic valve into aorta. So the minimum pressure required to open the aortic valve is at least 97. At least 97, right? If it's 96, that means the valve is not opening up. Both sides have equal pressure. So the left ventricle must minimum have a pressure of 97 to open the aortic valve compared to 80. So guess what? That means it's like somebody's lifting 60 pounds and suddenly now they have to lift 80 pounds. The more heavy you lift, the higher your muscle should get, the more stronger your muscle should get. So if the left, in this case, hypertension, so hypertension eventually leads to left ventricular hypertrophy. Left ventricular hypertrophy. It will lead to left ventricular hypertrophy. So the left ventricle has to get stronger to open the aortic valve. And that is not a good thing, right? For the left ventricle to hypertrophy. And that is because of increased afterload, right? So hypertension is the same thing as increased afterload. I'll just put this here so that way you guys know what that means. Okay, so increased afterload will lead to left ventricular hypertrophy. If the left ventricle hypertrophies, guess what? The left ventricle becomes stronger and stiffer, so it doesn't relax. So relaxation is decreased. It doesn't relax as before, which is the same thing as decrease in left ventricular compliance. It doesn't stretch as much as before. Stretching is really important. Remember this, the Starling law regarding myocardium or cardiac muscle. Okay, so if there's decreased relaxation of the left ventricle and there's decreased compliance of the left ventricle, that means filling pressure is increased. Filling pressure is increased. If the filling pressure is increased or diastolic pressure is increased, so that means left ventricular diastolic pressure, that means the ventricle will not fill completely. So the left ventricle does not completely fill up. And as a result, left ventricle cannot even pump in a good blood. So this leads to eventually pooling of blood. So this pressure, this increased filling pressure puts pressure on what? On the left atrium. So this will lead to left atrial hypertrophy. Left atrial hypertrophy, okay? And eventually this can lead to left atrial failure. So this will lead to pooling of blood within lungs, and that will cause edema. Pulmonary edema, because the blood through lungs doesn't go as much as before. It's piling up and it's piling up because there is resistance to blood flow because of the stiff left ventricle and atrium. So it leads to pulmonary edema. Pulmonary edema. If pulmonary edema occurs, that means pressure is high within there, and that puts a lot more pressure on the right ventricle, because right ventricle now has to push against high pressure in the pulmonary arteries and against the left atrium and against the left ventricle. Okay, so this leads to right heart failure as well. Okay, right heart failure. So we started with left heart failure and then ended up with right heart failure. Okay, so hopefully this makes sense. If not, you can ask me a question after I finish this lecture. Okay, so this is the issue here. Now Let's go back to our questions. In our question, do we have these signs of heart failure? Let's see. 80-year-old man, yes, by that age. And how long does this person have hypertension? 20-year history of hypertension. So remember, 20-year history of hypertension will lead to a lot. It's like you working out for 20 years, lifting more and more and more. Eventually, muscles will enlarge. They'll become huge. And if you've seen people who are big, muscular, they're not agile. They can't run as fast as someone else. They can't move and twist and turn. They're very stiff. Like their hands are rigid, their thighs are big, and then their chest is front when they walk. They can't even walk like how should I say, like a person who's not that big. So the stiffness, I hope you understand. Hypertrophy leads to stiffness. Comes to the physician's office because of 6-week history of progressive shortness of breath. Okay, so shortness of breath, dyspnea. Remember, dyspnea is a common cause of left heart failure. Okay, so I should have put it here, but let me just put it for you. Dyspnea, shortness of breath. So let's put here shortness of breath or dyspnea. Okay, so there you go. So left heart failure will lead to shortness of breath because of the pulmonary edema. Because of the pulmonary edema. He has had difficulty jogging one city block, which is with exertion, right? As demand for blood and oxygen increases, then you will become more and more shortness of breath, right? Because you cannot pump enough blood to the rest of the body because the heart is not filling completely. This is okay. So what else? His home medication include amlodipine. Amlodipine is calcium channel blocker. That's for hypertension. Lisinopril is ACE inhibitor. That's also for hypertension. Naproxen for osteoarthritis. Okay. His temperature is normal, pulse is normal, respiration, blood pressure is high. And you can see the diastolic I already highlighted. Let's highlight the systolic. Systolic should be 120 or something, 170. That's even higher. Why? Because the heart has to work hard. It has to contract stronger to push against the resistant, stiff aortic valve, against the high afterload. It has no choice. Pulse oximeter air is 95%, which is normal. Physical examination shows S4. So there you go. S4, we said it is associated with right heart failure. We have shortness of breath with left heart failure. We have S4 with right heart failure. Crackles. There's bilateral crackles, and that is sign of left heart failure. At lung bases, because there's fluid in the lung bases when you're standing. When you stand or sit erect, gravity is going to push fluid at the base or the bottom of lungs, right? Unless you lay down, it will be different. And there is JVD. Look at that. Normal JVD is about 7, I think. This is 12 centimeter. So 12 centimeter, and that tells you what? This is the right heart failure. So 2 cents for right heart, 2 cents for left heart failure so far. Echocardiogram shows a normal ejection. Okay. Now there's the thing. There's 2 types of heart failure. Heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Okay. And heart failure. So where am I gonna? I think I can write it down here. So heart failure with reduced ejection fraction, when ejection fraction is less than about 40%, okay, or heart failure with preserved ejection fraction. So usually you can think of preserved ejection fractions to be diastolic failure. Diastolic failure. The heart doesn't fill completely. Failure. So the heart chamber doesn't fill. It's a diastolic, right? Diastole means ventricular filling, right? Ventricular. When you talk about heart failure, okay, so there's another thing. The atria does not contribute to ventricular filling. The atria failure is insignificant because the atria only pumps about 10% of the end diastolic volume to the left ventricle or right ventricle. Okay, so atria is never an issue when it comes to heart failure. When we think of heart failure, we're only going to think of ventricles, either left ventricle or right ventricle. Okay, the thing is during diastole, the ventricle fills up with blood. Guess what? Almost 80% of the blood spontaneously flows into the ventricles, which is called ventricular filling. Ventricular filling. It doesn't require the atria to push blood. And then only about 20% of the blood is actually pumped into the ventricle by atrial contraction. Okay, so this is why when we say diastolic failure, we're thinking about ventricular diastole, when the ventricle is relaxing. okay, so which is ventricular filling. And heart failure with reduced ejection fraction is systolic failure. Systole means contraction, diastole means relaxation. But because the atria are not a big deal, this, when we talk about systolic diastolic failure, we only think of who? Ventricles. So when we say systolic failure, that means the ventricle are unable to contract and push blood out of the heart into aorta or pulmonary trunk, depending left or right. When we say diastolic failure, that means the ventricle is not filling with blood. Okay, so this is, I hope you understand that. Okay, so why did I even mention it? I'm not sure. I lost my train of thoughts. Let's go back to it. Oh, there you go, because echocardiogram shows normal ejection fraction. So therefore, this failure is heart failure with the ejection fraction, preserved ejection fraction, which is diastolic failure. Okay. Okay, so we did through all of this. Now, what are the choices? Decrease myocardial oxygen supply. So we know this is both systolic and diastolic failure, right? We know it's both, we know it's both left and right heart failure, but it's diastolic failure. Okay. One is anatomical failure, which is left and right heart, and the other one is functional or physiological, which is diastolic or systolic. Okay. So we know the symptoms of it, we know the signs of those things. Okay, now let's go over these choices. Decrease myocardial oxygen supply. So when the myocardium doesn't get enough oxygen, that is not heart failure. Heart failure is the end result of that. Decreased myocardial oxygen supply leads to angina, MI, vasospasm, and blah blah blah. An echocardiogram will show, guess what? It wouldn't show normal ejection fraction. It will show you hypokinetic segment of myocardium. It will show you hypokinetic segment of myocardium. Okay, so this choice A tells you about MI. It talks about ischemia, myocardial ischemia, whether it's angina or MI, okay, or whatever's the cause of myocardial ischemia. And then since we're given echocardiogram, so let me see. We have to talk about the echocardiogram finding, right? So that way you can relate to it. So echocardiogram will show for myocardial ischemia, it will show hypokinetic myocardium. It will show what? Hypokinetic myocardium. Okay, so hypokinetic myocardium. Or you can say hypokinesia, just hypokinetic myocardium, hypokinesia. Let's see what is, it's not choice A, right? So let's go over B. What is B? External compression of the right ventricle. When can the right ventricle get compressed? Either there is a myocardial tumor or cardiac tumor, a mass, right? So a mass can compress it. And what if it is pericarditis, like maybe tamponade? That's probably a better option. Tamponade. There's fluid in the pericardium that does not allow heart to expand. And so tamponade or mass compressing the right ventricle, guess what does it do? It leads to right heart failure. And on echo, you will see for tamponade equal pressure in all chambers of the heart. Okay, but we don't see that on echo, right? What do we see? Normal ejection fraction. Okay, impaired left ventricular relaxation. We said in this case, this is diastolic failure, so that means the left ventricle is not relaxing properly. Remember, we talked about it here. So that should be the answer. Decreased relaxation, decreased compliance. Okay, so far this seems like a good option. Okay, let's keep it. Increased turbulent flow across the mitral valve. This is mitral valve stenosis. So when the mitral valve is stiff and narrow, that means as blood travels through it, it's harsh. It travels with a harsh pressure, and it will produce a murmur. So in this question, if we had a murmur that was in the fifth, so mitral valve stenosis, the murmur will be I don't have room, so I'm going to talk not right. Okay. So for mitral valve stenosis, the murmur should be diastolic murmur in the fifth intercostal space, radiating to the axilla or armpit area. Okay, so that should be the option. think of it that way. So this is not mitral valve stenosis, so I'm not going to choose D. Obstruction of the left ventricle outflow tract. Remember, the left ventricle, we're not talking about aortic valve stenosis, but it's telling you obstruction of or to the left ventricular outflow tract. Just before the aortic valve, the area between the aortic valve and the left ventricle is called ventricular outflow tract. This area becomes stiff or narrow during hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. HCSM, I'll put it because again I don't have enough room. Or you know what, I can do this. So now you guys know this, so I don't have it. I will delete all of that. Okay, so hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, you would expect systolic ejection murmur. Okay, that is just in the upper sternal border area, and it is diastolic heart failure. That's true. The heart doesn't fill up, so it's almost like diastolic heart failure in this case. Okay, so it is diastolic failure. This is a good option. Actually, try to distract you. Diastolic heart failure. They're trying to distract me too, not just you guys. Okay, diastolic heart failure, because the outflow obstruction. So if this was the heart, this is the left ventricle, right? In the left ventricle, so then you have the aorta, right? Aorta like this. Even the aortic valve is here, but this area is the outflow tract, left ventricular outflow tract. So if there's sorry, it should be like this, yeah. If there's the septum, the cardiac septum becomes very thick. Intraventricular septum. The intraventricular septum becomes extremely thick in these scenarios, and that leads to this tract constriction, which produces murmur. Okay. Anyways, so diastolic heart failure, that's true, and there's a murmur, which in this question we don't have a murmur, so that would help us. This is not hypertrophic cardiomyopathy. Plus echo. What would echo show for hypertrophic cardiomyopathy? It will show thick interventricular, or just a ventricular septum. Thick ventricular septum. This is big deal. You should know that. Septum. Okay. As a result, maybe I will draw it for you. Okay. So this is heart. So left ventricle and right ventricle, the two atrias. Okay. So this area is the septum, right? Guess what? In this case, the septum becomes so thick. You know what? Let me do this. Where is my favorite? Bear with me, guys. I made a mess, so I have to fix it. So right atrium, right ventricle, left atrium, left ventricle. Okay. All right. So the issue here is in left ventricular hypertrophy that is caused by hypertension. The whole chamber is hypertrophied in equal proportion. The wall, the septum, they're all thick, but in equal proportion. But in hypertrophic cardiomyopathy, which is a genetic disease, it's a myosin heavy chain defect, right? Remember, this septum, the ventricular septum becomes so thick that it looks like a banana. They call it banana-shaped septum. And the left ventricle becomes even smaller as a result. So always pay attention to the septum. Okay, so echo will show that. Echo will show that the ventricular septum is extremely thick and banana shaped. Okay. All right. In this question, we don't see that. So therefore, this is unlikely to be hypertrophic cardiomyopathy. Okay. All right. So our choice is, the correct choice is still C, impaired left ventricular relaxation because of the hypertensive hypertensive cardiomyopathy. So this person is having diastolic heart failure due to hypertension. Okay, all right, let's go to our next. Okay, so this question is talking about a 75-year-old man is brought to the emergency room because of a 3-hour history of chest pain and shortness of breath. Pulse is 100 per minute, respirations 30 per minute, and blood pressure is 115 over 70 millimeters of mercury. Physical examination shows a laterally displaced cardiac apex and a systolic thrill in grade 4 out of 6 crescendo decrescendo systolic ejection murmur. Cardiac catheterization shows a pulmonary capillary wedge pressure of 45 millimeters of mercury. Which of the following sets of changes in this patient's left ventricle is most likely to be seen? Okay, so the question is talking about is what is the scenario in the left ventricle? Okay, where's my highlighter? Left ventricular. What do we see in the left ventricle? Okay, so in left ventricle, the stroke work, the myocardial conception, oxygen tension, and adenosine release. Okay, fine. So, but we should know what is happening in this person, right? Once we know that, then we will know we can apply it. First, we have to diagnose what's our main issue here. The main issue here is, I'm going to highlight it this time to see if we can figure it out. What are these things? A 75-year-old man, emergency room because of chest pain and shortness of breath. Look, in heart, almost every disease can lead to chest pain and shortness of breath or heart failure. The end result of all cardiac disease is what? Heart failure. Okay. So pulse is 100, respiration is 30, and blood pressure is this. Physical examination shows laterally displaced cardiac apex. So that means the heart is dilated. Okay. So the left ventricle, at least, the left ventricle is dilated, it's expanded. The heart, this is cardiomegaly. So the apex of the heart is laterally displaced. What do I mean by that? Maybe I should just draw it, okay? So before we go into, so if this is the normal heart, this is the apex. If the apex is laterally displaced now, so remember, if this is a human being and this is their arms, shoulders, okay, neck, blah blah blah, I did it too big. So laterally displaced, this is the lateral and this is the medial, right? So the apex is laterally displaced. That means the heart is enlarged. Now this is the heart. Okay. Okay. Let me erase this. So simply, when you see in a question laterally displaced, it means cardiomegaly. That's all. So just think of cardiomegaly for now. There's systolic thrill, and there's a murmur, crescendo, decrescendo, systolic ejection murmur. Whenever you hear crescendo, decrescendo, systolic ejection murmurs, this is one of the valve that is stenosed. If it is, depending on which location, so it could be either aortic valve stenosis or pulmonary valve stenosis. Okay. Cardiac catheterization shows pulmonary wedge. There you go. Pulmonary capillary wedge pressure is increased. So let's put all of these together to see what we get. So these are the main things. So and they're talking about left ventricle anyway, so even from that, you should, if you have no idea, at least you know it's valvular stenosis because of the murmur. Because they're talking about left ventricle, you should think of it's aortic valve stenosis. So let's just say it's aortic valve stenosis. Okay. In aortic valve stenosis, the murmurs, so murmur should be systolic ejection, because aortic valve pushes with a lot of force, it ejects blood, so systolic ejection murmur. And the murmur, initially in intensity, it increases and then decreases. That's why you will see this diamond-shaped structures on those diagrams. So this is called crescendo, decrescendo. Crescendo, decrescendo, that's what it means. Crescendo means increasing, decrescendo means decreasing in intensity. Okay, decrescendo. So what else? The murmur is heard best at second right intercostal space. So I'll put 2 right intercostal space, or you can say right upper sternal border. These are abbreviation. I use it for me so I can save room. Okay, so the murmur, where is the murmur heard best? In the second intercostal space, right of sternum. Okay, so usually the murmur and also aortic valve stenosis should have opening snap. Opening snap. Am I giving you extra information? Opening snap, because the valve is stiff and calcified in elderly. The number one cause of aortic valve stenosis in elderly and elders, I'm giving you extra information, my god, I think I'm never going to finish, is calcification. I'll just put calcium. In young people, the number one cause is bicuspid aortic valve. Bicuspid. Okay, in elderly it's calcification. This is 75-year-old, so I'm gonna think it's calcification. So the valve become very stiff, and initially when it opens it produces this sound. It's called the opening snap. So I'll be looking for that when it comes to aortic. So there should be opening snap, and usually S2 is loud. Okay, S2 is usually loud. There will be opening snap. There's systolic ejection murmur, which will be best heard in the second intercostal space, right of sternum, in its crescendo decrescendo, plus the carotid pulse would be delayed, okay, because the valve is narrow, stiff, not a lot of blood can leave through it, so the pulse would be delayed and or weak. You can say delayed or weak, one and the same thing depending which term is used. Okay, and it radiates to the neck, right? So this murmur radiates to the neck. Okay, so this is, do we have that? So of course, so far what we have in this question, we have crescendo decrescendo murmur, we have systolic ejection murmur, so we have those things. So this makes it, this doesn't really make it. There is no opening snap, there's no carotid stroke, delayed, nothing like that. Oh, what did they give you? So to make it aortic valve stenosis, they give you additional information, which is, I'm going to write it here. Okay, right here. I'll use red, so just to differentiate. And that is pulmonary capillary wedge pressure. It's 45, so the normal pressure is usually 17 on average, so 45 is high, so this is increased. If this is increased, that means blood through pulmonary valve to the pulmonary circulation is obstructed, blocked because of the aortic valve stenosis. If this was pulmonary valve stenosis, that means blood coming to the pulmonary capillary would be less. It would not pull up in the pulmonary capillaries. So this makes it aortic valve compared to pulmonary valve. Okay, so this is aortic valve stenosis 100%. Okay, so that's our diagnosis. Now they're asking you what should happen in the left ventricle. The stroke work of the left ventricle. So imagine this is the left ventricle, and here is the aortic valve. Okay, so this is normal. And so let's say a person with a diseased valve. So diseased valve will be narrow. Aortic valve stenosis is narrow. There you go. So this is aortic valve stenosis. Okay. So remember, green, this is normal. Normal, and then aortic valve stenosis, I have labeled it for you. Okay. So blood going through here is less. This is normal flow of blood, and in aortic valve stenosis, there is obstruction to blood flow, or blood exiting the left ventricle. So the left ventricle has to now work hard to push blood through this narrow valve. It has to work hard. So for each stroke is with each contraction, each heartbeat. So stroke volume will be decreased, right? So stroke volume is decreased in this case. With each heartbeat, it pushes less blood compared to a normal heart. Therefore, to push more blood, stroke work must increase. Stroke work must increase, right? Stroke work is work that is to push blood per heart contraction or beat. So it should be increased. So I'm going to say the correct answer is one of these. It's either A or B or C or D. But beyond D, all of the rest of them are incorrect. Okay, so I'm going to cause these below this, they're all incorrect already. So I decrease my choice by 50%. Now let's go to myocardial oxygen consumption. So if there's aortic valve stenosis with time, what will happen to heart with time? With time, the heart will hypertrophy. Okay, and plus, if stroke work is increased, that means the heart has to work harder. Therefore, it has to consume more oxygen. It has to use more oxygen to pump more blood. To pump more blood, and for the heart to contract much harder and stronger, you need more ATP. So to need more ATP, you need more oxygen consumption because remember, if you have studied your glycolysis and Krebs cycle, a single molecule of glucose in the presence of oxygen gives you 36 to 38 ATP. But to the process of glycolysis in the absence of oxygen or hypoxia, it gives you only 2 ATPs. Okay, so oxygen is essential for ATP production. So the myocardium has to produce more ATP to pump much harder, therefore it needs more oxygen. So oxygen consumption should be increased. If that is the case, the first two are correct. Oxygen consumption should be increased and it should not be decreased, right? So I'm going to say this is incorrect now. Let's keep moving. Okay, myocardial oxygen tension. Okay, myocardial oxygen tension. So the tension within the myocardium should be decreased because there's more oxygen coming. Okay, so that should be decreased. So there you go. We already know our answer. It should be B. Let's talk about adenosine. Look, if you're confused, if you cannot get myocardial oxygen tension, then guess what? You should look at adenosine. Adenosine is a byproduct of metabolism. It's a waste product. It is what? It's a waste product. How do we use that? If it's adenosine, if you take ATP and use it, eventually you'll become ADP, and then ADP is used to make AMP, and so with each time you use one phosphate, because phosphate is a high energy molecule, right? With each time you remove a phosphate from it, and eventually you remove a phosphate from AMP, you will be left with adenosine. So adenosine is a big deal. Adenosine is a byproduct of myocardial contraction. It's a waste product. You want to remove it, and it's a vasodilator. So adenosine concentration should increase. The more ATP you use, the harder your heart muscle contract. The more ATP is used, the more adenosine is produced. So adenosine should increase. Okay, if adenosine increases, then again, this is our choice. Our choice is B. Okay. All right. Hopefully you got this question. Let's move on to the next one. Okay, so the next question is: a 69-year-old man comes to the physician because of a recent onset of exertional chest pain that radiates to the left shoulder and jaw. 6 months ago, the patient underwent stent placement for significant stenosis of the left anterior descending and right coronary arteries. EKG taken during exercise stress test shows ST elevation in lead 2, 3, and AVF. Which of the following is the most likely cause of this patient's current chest pain? So we want to know the patient's current chest pain. What's the cause of this patient's current chest pain? So if he's having the chest pain, most likely he has MI, right? Or angina. Let's read the choices because that way it can guide me. Aneurysm the right coronary artery, new intima the right coronary artery. Okay, right coronary artery stent. Okay, everything is right coronary artery. Let's see. Let's do this question. So it's so the person's having chest pain. Chest pain. So chest pain that is new. Although it looks like he had chest pain before and he had stenosis of the left anterior descending and right coronary artery, and then a stent was placed. Okay, so he has chest pain after having stent placement. So that means 6 months ago he had a stent placed in those two coronary arteries, and now he has a new chest pain after the stent was placed. So maybe the stent is the cause or other things, but let's see. Stent was placed as well. Stent placed 6 months ago. EKG shows the ST elevation. EKG shows ST elevation and 2, 3, and AVF. So this ST elevation means right heart MI. Okay, so I'll say right STEMI because it's ST elevation, so we'll say right STEMI. Oh, what am I missing? ST elevation MI, right? That's what STEMI stand for. So I'll just put right STEMI. So this person having right STEMI. So therefore, everything will be the right coronary artery. Yeah, I thought it would be left in there, but there's no left coronary artery. Okay, so chest pain. And the issue here is what could be the cause of this? Okay, well, usually when a stent is placed, the stent should have the ability of releasing drug. So there are some stents called drug-eluting stent, which, remember, we did a previous question which was released, which we talked about like plaque formation, how to prevent the plaque from formation. We said you can use aspirin, you can use epseximab, you can use clopidogrel, you can use celestazol, all those medications. So we want a medication. Usually the stent will be releasing those medications to prevent a thrombus formation. Okay, so if this is a coronary artery and here a stent is placed, remember a stent is, so this ring will be a stent. Let's call it a little bit rough. Okay, stent is a foreign body. So a foreign body has more tendency of activating platelets, thrombus formation. It's not as smooth as endothelium. Okay, so the body tries to cover the stent with endothelium. That's the normal function. So these vessels wants to cover the stent with endothelium, so that just to prevent thrombus formation. That's a natural process. Okay. Aneurysm, stent does not cause aneurysm. Aneurysm simply means dilation of all layers of the blood vessel in this case. Okay, so if this is a blood vessel and a part of it dilates like this, it expands externally, that's aneurysm, just like diverticulum. So that's unlikely. It could happen, but unlikely with a stent, unless the blood vessel is already damaged during stent placement. So there has to be some sort of damage from the inside of the blood vessels, so the blood vessels can expand and dilate. Maybe infection, maybe syphilis, for example, or maybe a cholesterol plaque, things like that. So I'm not going to choose in this case A. So a aneurysm is unlikely. It's possible, very unlikely. Dissection of the right coronary artery. Again, during the procedure, so this will the aneurysm will be like few days, a month after the procedure. Okay, once the vessel wall is weak, and then with high pressure it expands and becomes dilated, and that's aneurysm. Dissection is rupture of either aneurysm or anything else. In this case, they're telling you dissection of the right coronary artery. If the procedure was rough and the surgeon was not trained and so forth, and it caused damage to the right coronary artery, then it comes to dissection. Dissection will be immediately. It will be immediate after the procedure. So it wouldn't be like 6 months after. Okay, so this we're talking about 6 months after, right? So the stent was placed 6 months ago. So I'm not going to choose this as well. Neo means new entima formation in the right coronary artery. Yes, as the stent is, remember, covered with endothelium. So that's new entima. So that's possible. Okay, that can happen. It takes time. Thrombosis of the right coronary artery, but as I told you, most stents have drug-eluting stents. They elute and they release a drug slowly to prevent thrombus formation. In this case, if it was thrombus, we would have something, but it doesn't look like this would be a thrombus because of that. So it is possible, but again, not as likely as neoentima, or not as likely as other things. Vasospasm, no, vasospasm usually related to smoke and other things. A stent is not. So the best option will be neoentima formation. This is a very common complication of stent placement. Okay, so stent placement can cause all these are complications of stent, but specifically over a long period of time, neoentima is the most common. Okay, All right, I'm tired. Hopefully this was helpful. I will see you guys.